Chairman.
Dr. Mendolsohn. Dr. Mendolsohn, welcome.
Mr. Chairman, Senators, good afternoon. There are many super techniques and advancements in eye surgery. Unfortunately, God forbid at times there are complications. During the actual performance of the surgery, it's very, very rare for a bad thing to happen. The danger to the eye actually most commonly happens during the postoperative period. Potential complications including bleeding, infection, macular edema, as well as retina detachment, swelling of the cornea, and glaucoma as well. The good news is most complications can be treated. The key is to pick it up early and jump on those complications. Unfortunately, we have a phenomenon that has a rapidly increasing phenomenon in Florida, whereby an ophthalmologist does an eye surgery and then, unfortunately, inappropriately does not see that patient again. There are many times where they do the surgery and not even once see the patient postoperatively. This is an individual, cataract surgery performed, surgery went well, surgeon did not follow up the patient, the optometrist did follow up. Unfortunately, corneal ulcer developed. I have other cases, corneal ulcers. The good news is these eyes were saved. The bad news is they subsequently required corneal transplant surgeries. In addition to an infection in the cornea, where you make the opening incision in the eye, there can be an infection as well. That's an infected bleb. The infection can permeate into the eye, and very rapidly, 12, 24 hours, it has the potential to destroy a human eye. Senators, this is something a little bit different. In the process of removing a cataract, there are times when a little bit of the cataract material is left behind. That's called cortical fluff, and it's accepted. You remove 98, 99%. If there's a little cortical fluff, that's no problem. You keep an eye on things just to make sure that the pressure doesn't go up and the eye does fine. Here's another example, cortical fluff again. It's appropriate to just keep an eye on that eye. If you look very carefully, this is a subtle little differentiation. This is not cortical fluff. This is an infection in the eye called endophthalmitis, which very rapidly can and will destroy a human eye. The subtle little differences that a surgeon is able to pick up can be the difference between a save and a God forbid. A personal story, my mother, mammogram age 63, a subtle lesion. It was not picked up. Age 64, repeat mammogram. It really should have been picked up again. It was not. Unfortunately, it was brought to our attention, horrible pounding headaches. She had metastasis to her skull bone. She passed away at age 65 because that subtle lesion was not picked up. A subtle thing is the difference between a save and a God forbid. This is a different case, endophthalmitis. If it were treated early, the eye could have been saved. Pus in the eye is gone. Another case where I personally was called to see this patient, hours and days later, there is nothing that can be done to save the eye. Senators, you've had a lot of talk about negative formulary Coumadin, warfarin, blood thinners. Well, it's the same senior population that is cataract surgery. It's on these blood thinners. Here's a little bit of blood in the eye. It's called a hyphema. Again, you keep an eye, watch things closely. Here's a little bit more blood. Now the surgeon's faced with the question, do you stop the blood thinners? Do you keep them going? Do you stop them? Do you use half a dose, full dose? What do you do? The eye in this case is totally full of blood. Here's a little blood in the back of the eye. Again, the same questions with blood thinners. The problem is blood you watch closely, but sometimes inappropriately. This eye actually, there's a total retina detachment. If that were picked up right away, it would have been a very treatable thing. What's this? A bloody mouth. Patient had cataract surgery. Surgeon did not see the patient postoperatively. Blood in the eye called a hyphema. The optometrist correctly Put the patient on drops to lower the pressure. One of the active ingredients is sulfa. Because there was blood in the eye, the feeling that, well, some blood around the mouth, that's part of whatever mechanism's causing the blood, probably the blood thinners. The patient became very ill. The spouse called the internist, said, my spouse is a sick puppy, something's very wrong. I was asked as a favor, please, can you see this person? Senators, if you ask 100 out of 100 physicians looking at that mouth, that is a toxic reaction to sulfa called Stevens-Johnson syndrome. Another day or two, this person would have been dead. Instead, they were admitted in IV therapy intensive care for 10 days, Hollywood Memorial Hospital. Part of the problem with the complications is there's a safety net, the emergency room, which you'll talk about later, and unfortunately, surgeons having to go back later and do corneal transplants. The number one cause of cornea transplants, corneal edema after cataract extraction. What that means is, unfortunately, either during the actual performance of cataract surgery or postoperatively, the eye was pushed off the cliff and the patient needed cornea transplant surgery. Here's an intraocular lens scraping against the cornea, caught early, would have been fine. Unfortunately, needed transplant surgery. I'm going to zoom along, same story, many eyes requiring cornea transplant surgery. I'm a cornea transplant surgeon. I'm happy to do cornea transplants, but we don't want to have to do surgeries that should never have been necessary in the first place. Switch gears. Before LASIK, there was radiokeratotomy. Here you have the procedure being performed. If you can get a corneal ulcer, this was referred early enough, ulcer treated. This was referred too late, patient needed a cornea transplant. LASIK. LASIK's the hot new procedure. We have LASIK surgeons, again, ophthalmologists, who do the surgery and never, ever, ever see that patient again. Well, if the complications picked up early, a corneal ulcer, you treat with antibiotics and the eye's fine. But if it's picked up later and the optometrist postoperatively sits on it, they could need a corneal transplant. I'm going to go very fast. A corneal transplant's not a trivial little thing. We can restore eyesight, take the donor cornea from someone who, God forbid, passes away. It's put in storage media, antibiotic, and preservatives. Of course, analysis is done on the donor to make sure they didn't have HIV, hepatitis, etc. At the surgery center, the cornea is turned upside down, little instrument like a guillotine. And then we have the donor tissue, looks kind of like a contact lens. Patient is lying on their back looking up to the ceiling, the eye's immobilized, and in the surgical technique, the donor tissue is here you see the cornea being raised. It's a major procedure. Corneal sutured in, procedure's complete. One problem, potential complications again. So there are many people who are having subsequent surgeries that if the ophthalmologist would see their patient postoperatively, which is appropriate, which it seems that every other surgical specialty can somehow live up to the Hippocratic Oath and see their patient. Senators, these eye surgeries are done in an operating room. This is not a barber shop. It's not a beauty salon. This is not a trivial thing. This is major surgery done in an operating room. If you were under those drapes, I think you would want your surgeon to see you again. And for your constituents, we think they deserve better. If they have eye surgery, I think you owe it to them, for your constituents and the seniors and all patients in Florida. If eye surgery is performed, the surgeon must see their patient postoperatively. Thank you very much, and I'll be glad to answer questions.
Thank you, Dr. Mendolsohn. Anita Rink.
Question, if I could.
Dr. Mendolsohn, if you'd come forward.
Yes, Senator.
Thank you, Mr. Chairman. Dr. Mendolsohn, one of the things we've heard is that there is a concern that in some areas, ophthalmologists are flying in, providing some type of surgery, and then delegating to the optometrist. If there is since we're obviously all concerned on all sides of this, of the health and safety of the patient and their vision, what is your understanding of a situation in which that is occurring, the ophthalmologist leaves, an optometrist is supposed to be handling something, but it's beyond their scope of experience? Is the person, and presumably the optometrist does not have privileges at a local hospital, what is happening? Is this person going to the emergency room and...
Sir, the patient's being sent to the emergency room, but that's not just with the itinerant surgeons. We have a surgeon in Broward County who openly admits that if there are problems, that he instructs the optometrist, just send them to the emergency room. They are being referred to the emergency room. That is the safety net, but it's an inappropriate safety net.
Okay, thank you.
Senator Cowan. Dr. Mendelssohn, a question?
Yes, please, and I appreciate this. Generally speaking, just so we get a perspective, how long is the postoperative time? Are there 6 and 7 meetings after surgery normally by anybody?
Senator, it all depends on the procedure performed and how the postoperative course is progressing. Medicare utilizes a definition of a 90-day global period, figuring by 90 days the eye is safe and sound. There are procedures like a cornea transplant, where certainly it takes longer. Others might be a little quicker. Medicare, though, HCFA utilizes a 90-day postoperative period window. And
if I could just follow up with this one quick question. So therefore, if an ophthalmologist was treating all the postoperative care, would that be all inclusive of your fee for the surgery?
Yes, Senator. It's a whole global fee, the performance of surgery, and all the care that's required postoperatively during that 90-day global period. Whether the cornea transplant patient, I'll see them 15 times in the 90 days, while for a cataract it'll be less frequent.
And so then when an optometrist sees a patient, has there been any cost analysis when an ophthalmologist refers to an optometrist and then they charge? Is there
No, it's actually, there's one given global fee. The ophthalmologist can take the global fee and utilize it for all the care, or the way to beat the fee splitting that occurs, fee splitting in Florida is illegal. They will delegate postoperative care to the optometrist, but then if the eye runs into trouble, the surgeon's not available and the patient ends up being sent to the emergency room.
Senator Ginny Brown-Waite.
Thank you. Dr. Mendelssohn, just a follow-up question.
Yes, Senator.
With the 90-day global follow-up period, what I want to make sure that we're not going to be doing here, and just kind of walk me through it, okay? If, for example, you see your patients for the 90-day, however many visits they need to make, at any point, do you turn this over to a nurse or a nurse practitioner, or are you the attending physician seeing that patient? Because what I want to make sure we're not doing is lowering that level of care when they go for these follow-up visits.
Senator, either I personally or one of my ophthalmologist partners is responsible for each and every postoperative visit. That's what the practice has done for 30 years. I've been in practice for 15 years. We have 100,000 active patients. We have never, ever abandoned our patients.
All right. Are there any other questions? Senator Webster, we're on your bill as amended. Are there any questions of the sponsor? Is there any debate?